Hey guys, it's been a long time. I hope everyone had a great Thanksgiving holiday, and looking forward to heading back to clinicals tomorrow. Um, this presentation I've been thinking about for a while, how to do cardiac physiology in less than 30 minutes, and thought back to the lecture we had at USIS. Dr. D'Angelo did a pretty good job of covering major topics. So, draw inspiration from his lecture. I went out and purchased a purple dress shirt, put some gel in my hair, and did 7 push-ups. So here goes nothing. Like I said, the time limits of this presentation are pretty great. So I tried to go through and pull as many of the major concepts and most common things that I've seen in some of the review books that I've done, some of the lectures that I've studied offline. So our objectives today, we're just going to take a bird's eye view of cardiac anatomy, basic physiology of blood flow through the heart, and the electrophysiology of the cardiac cycle. We're going to review cardiac action potentials in pretty good detail. We'll do a quick overview of the excitation-contraction coupling mechanism of coronary smooth muscle. Review coronary blood supply and autonomic innervation of the heart. Discuss determinants of left ventricular function. And then review the components of a cardiac volume pressure loop as they relate to physiology and some of the things we can draw from that diagram. So the heart is a single organ consisting of 2 muscular pumps within a complex connective tissue skeleton. Each pump is comprised of 1 atrium, 1 ventricle. The right atrium of the heart receives deoxygenated venous blood from the systemic circulation via the superior and inferior vena cava. This blood then passes through the tricuspid valve into the right ventricle, where it is actively pumped through the pulmonic valve into the low-pressure pulmonary circulation via the pulmonary artery. While traversing the vasculature of the lung, carbon dioxide diffuses out of and oxygen into the circulation via the alveolar capillary membrane. The freshly oxygenated blood then travels back to the heart via the pulmonary vein, enters the left atrium. This blood then passes through the bicuspid or mitral valve into the left ventricle and is subsequently ejected through the aortic valve into the high-pressure systemic circulation via the largest artery in the body, the aorta. Notice the pressure differences for each chamber and vessel on the diagram, which is an easy way to remember these pressures. So think of them in terms of monetary values. So the right atrium, 0 to 8, you have nickel. Right ventricle and the pulmonary artery, you have a quarter. 15 to 30 would be the range there. Left atrium, 2 to 10, so we put a dime there. And then the left ventricle and the aorta, somewhere between 100 and 140 systolic, and these are all systolic pressures, so we'll add $1.25 to there. So just an easy way to kind of imprint that image into your mind, think about the pressures in the different chambers of the heart. This intricate pumping mechanism is the product of a series of synchronized electrical and mechanical events that we're going to talk about in greater detail. So the muscle fibers of the heart can be divided into 3 major classifications: atrial, ventricular, and pacemaker or conducting cells. All cardiac muscle cells, despite their classification, have the special innate ability to self-depolarize, as a phenomenon known as automaticity. However, each group has a slightly different intrinsic rate at which it is able to repeat this depolarization. Cardiac myocytes also have special intercalated discs, more commonly known as gap junctions, through which the cytoplasm of neighboring myocytes communicate directly. This allows quick and seamless passage of depolarizations across the entire heart muscle, creating a smooth and orderly contraction of the entire muscle, which gives the heart its efficient pumping capability. Specialized areas of dense conducting tissues create nodes and pathways by which depolarizations travel between the atria and ventricles. The sinoatrial or SA node is known as the pacemaker of the heart. During normal cardiac physiology, this group of pacemaker cells, located just posteriorly to the superior vena cava's entry point into the right atrium, is the site of initial depolarizations for each cardiac contraction. These specialized pacemaker cells have outer membranes that leak sodium and calcium, and therefore have a less negative resting membrane potential, somewhere around -50 to -60, versus -80 to -90 of the ventricular myocytes. This leakiness results in several things. 1. A near constant inactivation of voltage-gated sodium channels. 2. A threshold potential of -40 millivolts primarily activated by ion movement across slow calcium channels. And 3. Regular spontaneous depolarizations, somewhere between 70 to 80 per minute. Absence of direct connections between atrial and ventricular myocytes diverts depolarizations through the AV node, atrioventricular node, located in the septal wall of the right atrium, anterior to the opening of the coronary sinus, and superficial to the insertion point of the tricuspid valve's septal leaflet. While it only takes approximately 0.04 seconds for the impulse to reach the AV node from the SA node, it takes almost 3 times longer, or 0.11 seconds, for the impulse to make its way through the slow calcium channels of the AV node cells. This diversion and subsequent slowing of the depolarization allows adequate time for the contraction of the atria, also known as the atrial kick, which accounts for 20 to 30% of ventricular diastolic filling. That's an important number to remember. Like all other cardiac myocytes, the cells of the AV node have the intrinsic ability to produce their own initial depolarization, in the absence of receiving a depolarization from the SA node above. The intrinsic rate of the AV node is 40 to 60 beats per minute. Because the SA node's intrinsic rate is faster, as long as it is functioning normally, it will continue to be the pacemaker of the heart. The lower fibers of the AV node come together to form the common bundle of His, which divides into the right and left bundle branches and continues throughout their respective ventricular walls as a network of conducting pathways known as the Purkinje fibers. The cells of the bundle of His, bundle branches, and Purkinje fibers are the fastest conducting of the heart, allowing near simultaneous depolarization and contraction of both ventricles. It usually takes less than 0.2 seconds for the depolarization to pass from endocardium to epicardium. Potent inhaled anesthetics are known to depress SA node automaticity, more so than AV nodal depression. This can lead to junctional tachycardia, no P waves, and a rate greater than 60. If anticholinergics such as atropine or glycopyrrolate are administered for sinus bradycardia during inhalational anesthesia, this is what you'll see. The resting membrane potential of a cardiac myocyte, ventricular in this case, is -80 to -90 millivolts due to a relatively higher permeability to potassium from inside to outside the cell than sodium permeability in the opposite direction. This outward movement of positive ions down its concentration gradient and the subsequent attraction of impermeable anions towards the inner membrane are responsible for the net negative charge on the resting membrane. Resting membrane potential corresponds to phase 4 in the drawing above. Once a depolarization is initiated by the SA node or another adjacent pacemaking cell, voltage-gated sodium channels are activated and an influx of sodium results in depolarization to somewhere around a positive 20 millivolts. This rapid depolarization, or phase 0 on the diagram, is followed immediately by an early rapid repolarization, or phase 1, as a result of inactivation of the sodium channels and a transient increase in potassium movement out of the cell. This transient repolarization is cut short due to the activation of L-type, which stands for long-lasting calcium channels, which allow the movement of calcium into the cell, negating the positive potassium ions that are moving out. This phenomenon creates a plateau, known as phase 2 on the cardiac action potential, that is not seen in skeletal muscle action potentials. Final repolarization, or phase 3, is a result of the inactivation of the slow calcium channels and an increasing permeability to potassium. As you can see from this diagram, the action potential of the pacemaking cells in the SA node is quite different from that of the atrioventricular myocytes. The major difference, which gives these specialized cells the ability to spontaneously depolarize, is seen in phase 4. These cells contain funny sodium channels which allow leaking of sodium into the cell and are activated by the previous action potential's repolarization. This ensures that each action potential is followed by another. Upon reaching threshold, T-type or transient calcium channels are activated and result in the phase 0 upstroke. Repolarization, or phase 3 in this diagram, is due to the outflux of potassium ions. Once an action potential is created, it travels along the sarcolemma, or the myocyte membrane, and into crevices known as T-tubules, where it activates voltage-gated calcium channels known as dihydropyridine receptors. This is another L-type calcium channel. These receptors cause a conformational change in adjacent ranitidine receptors, which are calcium channels embedded in the membrane of the sarcoplasmic reticulum, or SR. The SR is an organelle of myocytes that serves as an internal storage of large amounts of calcium. Upon activation, this calcium is rapidly released and serves as the catalyst to excitation-contraction coupling of muscle contractions. Calcium ions bind to troponin C, which causes a conformational change resulting in tropomyosin being removed from its resting position over the active binding sites of the actin protein. This exposure of the binding site of actin allows myosin cross-bridges to attach and contract. As this process is repeated many times over, the net effect is the shortening of individual myofibrils, and ultimately shortening or contraction of the entire muscle group that was targeted by the original action potential. Coronary perfusion pressure is the difference between diastolic pressure in the aorta and the end diastolic pressure of the left ventricle. Coronary perfusion can therefore be reduced by decreases in arterial diastolic pressure or increases in left ventricular end diastolic pressure. It can also be reduced by an increased heart rate due to the reduction of diastolic filling time. The left ventricle is almost entirely perfused during diastole, whereas the right ventricle is perfused during both systole and diastole. It is also important to note that the endocardium is most vulnerable to decreases in coronary perfusion pressure because it is most affected by the ventricular wall pressures of systole and diastolic overfilling. The SA node is supplied by the right coronary artery in 60% of the population, and by the left anterior descending in the remaining 40% of the population. In the average adult male, coronary blood flow equals approximately 250 mLs per minute at rest. And it's also important to remember that autoregulation occurs between a coronary perfusion pressure of 50 to 120 millimeters of mercury. As you can see from the slide, the left main coronary artery divides into the left circumflex, the left anterior descending, and the posterior descending artery in 15% of the population. This is known as a left dominant coronary blood supply. The right coronary artery divides into the posterior descending artery, or I guess supplies the posterior descending artery in the remaining 85% of the population, and this is known as a right dominant coronary blood supply. And as we already discussed, coronary perfusion pressure equals the diastolic pressure in the aorta minus the end diastolic pressure in the left ventricle. Autonomic innervation of the heart includes parasympathetic and sympathetic input. Parasympathetic innervation is primarily to the atria and conduction tissues. Remember, parasympathetic physiology is cholinergic via acetylcholine action on cardiac muscarinic or M2 receptors, and it affects a decrease in chronotropy, which is rate, dromotropy, which is conductivity, and inotropy, which is contractility. Sympathetic innervation is via cardiac sympathetic nerves, which travel via the stellate ganglion after emerging from the first through the fourth segments of the thoracic spinal cord. Recall, sympathetic physiology is adrenergic via norepinephrine's action on beta 1 and beta 2 receptors. Be aware that beta 1 receptors are the primary adrenergic receptors in the heart. Sympathetic stimulation affects an increase in chronotropy primarily, but also increases inotropy to a lesser degree. Autonomic influence on coronary perfusion is considered weak. Coronary arteries contain both alpha 1 and beta 2 receptors, although sympathetic stimulation usually increases blood flow due to beta 2 predominance. Parasympathetic nervous system innervation is minimal in the coronary arteries, but also promotes dilation. One of the most basic measurements of the ventricle's pumping function is cardiac output, or CO. This is derived as the product of heart rate, or the number of contractions per minute, times stroke volume, the amount of blood ejected per contraction. In order to relate this volume to body size, cardiac output can be expressed as cardiac index. This is the quotient of cardiac output divided by body surface area. The normal range for cardiac index is 2.5 to 4.2 liters per minute per meter square. These baseline measurements of ventricular function and their respective determinants provide healthcare providers a systematic approach in determining causes and potential treatments for situations of decreased perfusion. Stroke volume is dependent on three major factors: preload, afterload, and contractility. Each of these factors has specific implications on stroke volume and ultimately cardiac output. Preload refers to end diastolic blood volume and has a number of dependent factors: blood volume, blood distribution, rhythm, specifically atrial contractions, and heart rate. The proportionate relationship of preload to stroke volume is best described through Starling's law of the heart, which highlights the increased contractility of the heart muscles in response to stretch caused by increased preload. This effect occurs only to a point at which the muscle fibers may be stretched too far and no further increase in contraction force is appreciated. This effect is detailed by the Starling's curve in Figure 20-4 on page 353 in Morgan and McHale's 5th edition Clinical Anesthesiology. Afterload refers to the amount of work the heart muscle must do in order to overcome resistant forces. Two of these major resistant forces include ventricular wall tension and vascular resistance. This vascular resistance for the right ventricle would be pulmonary vascular resistance, and for the left ventricle, obviously systemic vascular resistance. The component of vascular wall tension is described by the law of Laplace, which describes the following relationships. Wall tension is directly proportional to interventricular pressure and radius, while wall tension is inversely proportional to ventricular wall thickness. Vascular resistance is described by Passul's equation, identifying proportional relationships between resistance, or afterload in this case, and blood viscosity, as well as vessel length. Now, clinically speaking, blood viscosity could create potential impact. However, vessel length doesn't generally change acutely. The most important relationship of the equation, however, is the inverse proportionality of vessel radius to resistance. This relationship is exponential, in that a radius reduced by half will produce a 16 times increase in resistance. Those are numbers that you'll want to remember. Contractility is commonly the least variable component of stroke volume and thus cardiac output, but it can be altered via intrinsic, such as neural or humoral factors, or extrinsic, such as pharmacologic influences. As previously mentioned, Starling's law of the heart links contractility to preload, or end diastolic volume. Sympathetic nervous system input has the most profound effect on inotropy, or contractility. Endogenous or exogenous norepinephrine increases intracellular calcium release via beta-1 receptors, causing stronger cardiac muscle contractility. Myocardial contractions are weakened by hypoxia, acidosis, catecholamine depletion, and muscle death secondary to ischemia or infarction. Another component, and the most important clinically, of ventricular function is known as ejection fraction, and it's the final concept for this slide. Like I said, it's very important because it's the most commonly used clinical measurement of systolic efficiency. Ejection fraction, or EF, is defined simply as the portion of the end diastolic volume that is ejected by a ventricular contraction. The equation, to write this in an equation, you would take the end diastolic volume minus the end systolic volume and divide that number by the end diastolic volume. Normal ejection fraction is somewhere between 59 and 75%, according to the numbers in Morgan and McHale. The final concept of this presentation is the volume pressure loop and its bird's eye view of the cardiac cycle. I chose this diagram specifically to review because it identifies all the components of the loop and also shows how the loop changes dependent on the type of increased work being done by the myocardium. The important components of the loop are numbered 1 through 4. So number 1, so we'll just look at the dark loop for each of these diagrams in the figure. So A, B, and C, the dark loop is all the same. So the point where number 1 is indicated is where the mitral valve closes, and this is also identifies your left ventricular end diastolic pressure and volume. Number 2 is where the aortic valve opens. Number 3 indicates aortic valve closure and is also the point of left ventricular end systolic volume and pressure. And number 4 indicates the volume and pressure at which the mitral valve opens. Other important parts of the loop include segment 1, 2, so the line between number 1 and number 2, which identifies isovolumetric contraction. So there's no change in volume, but you get an increase in pressure. And segment 3 and 4, which identifies isovolumetric relaxation. Again, there's no volume change, but pressure releases, or decreases, I should say, because the muscle is relaxing. When reading these diagrams, it is important to realize that the x-axis is volume and the y-axis is pressure. Take notice, there is no component of time in this diagram. It is simply a comparison between volume and pressure. Notice also that end diastolic volume and end systolic volume can be determined from each of these diagrams, and thus ejection fraction can also be calculated. The altered diagrams above give us an idea of how ejection fraction, and thus ventricular efficiency, is affected by increased preload, increased afterload, and increased contractility. If you look carefully, you'll see that increased preload increases the end diastolic volume minus end systolic volume difference, and it also increases end diastolic volume in and of itself. So these two numbers increasing causes an increase in cardiac output, obviously, but it wouldn't necessarily be expected to change the ejection fraction very much, if at all. However, the second diagram shows that drastic increases in afterload affects a significant decrease in the proportion of end diastolic volume that is ejected in comparison to the baseline end diastolic volume staying the same. So in other words, the difference between end diastolic volume, or 0.2, sorry, well, 0.1 or 0.2 for the volume, because that's the same number for volume. And 0.3, which is end systolic volume, is actually smaller. So that proportion of end diastolic volume that's ejected is actually smaller. End diastolic volume stays the same, so you expect your ejection fraction to decrease, which is obvious from the diagram. The third diagram in the figure shows the result of increased contractility. So that difference between end diastolic volume and end systolic volume is actually increased while the end diastolic volume stays the same. Therefore, ejection fraction is a larger proportion of that end diastolic volume, and so it's increased. And again, you can see that from the diagram pretty clearly. It's important to remember, however, that Starling's law identifies a very important concept of cardiac function and efficiency with regards to the relationship between increased preload and resulting contractility. There is a max length at which the cardiac myocytes will not continue to benefit from further stretch and may actually decline in the amount of work or contractility which they can do. Again, this was a very short, concise presentation. I attempted to cover as many of the major components of cardiac physiology as was put forth in Morgan McHale, supplemented by Barish and Costanza. I hope you got something from this. If you have any questions, feel free to join in on my discussion board, and be happy to try to clear anything up from the reading that I did. These are my references. Thank you guys, and hope you have a good rest of the semester, and Merry Christmas, Happy New Year if I don't hear from you or see you before then.